All right, you guys, my name is Emma. I am one of the educators here at this campus. I teach the ECMO, Impella, and CentroMag class. I used to work in CV ICU. I love CV ICU with all of my heart, but I like to help out with everybody else too. I can help you with a lot of things except for brain. I know you have two hemispheres, they cross and go down, and that's about it. Everything else, I'm like, don't even trust me to do the NIHSS scale for these patients too. I'm like, is it subjective? It's not, it's quantitative, but I feel like it's qualitative, So here we're gonna talk about ECMO. We'll go through this device. I'm first gonna get a raise of hand. Who's taking care of a patient with ECMO? Awesome. Glad to see there's people in here who have not too, because we're gonna do a brief run through on ECMO and just give you a little background about it too. So there are two main types of ECMO that we can have with our patients. We can have VV ECMO, veno-veno, or veno-arterial VA ECMO. So VV ECMO is for your lungs. So when your lungs have failed, I'm gonna cannulate in your venous system to oxygenate your blood to help that blood flow through your whole body. But I am relying on your heart to pump that blood throughout your whole body. So if your heart goes down, I need to do compressions and get that blood flowing too. But VA ECMO, my heart has gone down. I don't have any oxygen around my heart, so I'm gonna put you on VA ECMO. I still have an oxygenation issue, but it's not, my lungs have gone down. If my lungs and heart have gone down, then I'm gonna put you on both VV and VA ECMO. So that would be a VAV ECMO. So with that being said, we have our machine over here. We have a lot of tubes and wires hooked up to it. So first, you have your green and yellow cannula, or tubes. My yellow one is for my gas line, and then my green is for my oxygen. Yellow is just so that I can blow the gas throughout the system, and green is so that I can get my concentrated FiO2 back to my patient. Those two lines are gonna connect over here to my flow meters and my FiO2 knob. So what are we breathing in air FiO2 concentration right now? 21%. So that's why this knob over here goes from 21 up to 100%. I never want to go less than 21% because I'm oxygenating the blood right away. So if I'm deoxygenating the blood, I'm not helping them at all. Then over here, my knob, this is where I can control how fast that sweep or that gas is going through the pump, so I can control how much CO2 is pulling off of my patient at any time. So sweep, I can go up in liters per minute for it over here. You never want it to be less than 0.5 because then I'm not helping any oxygen or anything get through my pump at all either. So for my sweep, I'm gonna check my patient's ABG and see what is your CO2. If your CO2 is high, I can increase my sweep to pull off my CO2. If I'm not on ECMO and my CO2 is high, how do I compensate for that? What organ compensates for us? Where does our bicarb come from? Our kidneys. So if my kidneys have failed, I have no compensatory matters for it too. And also, my kidneys take up to 3 days to compensate for that low pH balance too. So my lungs, if my CO2 is really high, do I have 3 days to wait for my kidneys to kick in to compensate? No. So that's why we intervene, we intubate, we give them extra oxygen, we try and make them breathe slower or faster to control what their CO2 is before we go to this ECMO. Then from here, we have the back of the pump where we actually have our pump and our oxygenator right here. And this is where all of our gas will be connected so that I can pull off from the blood directly the CO2 and the oxygen too from this. So with this all being said, how much do you think it costs to cannulate a patient on ECMO for 1 day? We start at $100,000 for the first day of cannulation. This device, how long do you think this device is FDA cleared for? 6 hours on bypass. So we do a lot of things here in medicine that are not FDA cleared because we see more benefits than repercussions for a patient. So if the benefits outweigh the risks, I'm going to do it. We've had a patient over a year on ECMO before she got her lung transplant. She did amazing, and you can see her dancing and moving in the hallway, and she looks completely normal. except for she has 600 mLs of blood sitting outside of her body while she's walking around and she's on this support. Now 600 mLs of blood sitting outside of a patient's body. That's 2 units of blood. Your hemoglobin binds to all of that oxygen. So if I don't have hemoglobin attaching to the oxygen because I don't have hemoglobin, I'm not going to oxygenate well at all. So with that, what type of patients go on ECMO mainly? The pre-transplant patients. Do we like to give blood to pre-transplant patients? No, because they're going to get more HLAs. It's going to be really hard to then find them an organ that matches with them. So we're going to try and keep their hemoglobin a little bit lower than what we'd like it to be. That magic number of a hemoglobin of 7 is a magic number. They chose it because it's a lucky number. There's no evidence to show that 7 is the perfect number for every single patient. Some patients will be fine with a hemoglobin of 6.5. Some of them will look like absolute garbage at a hemoglobin of 8.5 though. So look at your patient. Are they looking like they're not oxygenating well? They could benefit from a unit of blood. And we have to weigh, is it a beneficial thing to give them some more HLAs, to give them more oxygen carrying capacity? Or should I just leave them and keep their hemoglobin at 5.5 just in the hopes that they get a transplant offer today or tomorrow? All of those thoughts and decisions go into when we should cannulate and how we manage these patients afterwards too. So on this device here, we have a backup hand crank where we have a backup because we need to make sure we can continuously have flow for this patient. If my patient doesn't have flow over here and it clots off, then they get no support. They're on this device for a reason. We just don't put it on every single patient just because some patients really do need it. So when we have to go from the pump to our backup pump, we have a very limited time frame. And that's depending on how anticoagulated your patient is. What is their ACT, their activated clotting time? Is it 75? You have 75 seconds. I can't do this swap in 75 seconds. If their ACT is 30, you have even less time. What's their PTT? Were they anticoagulated before? Do I have time to run to the Pyxis to give them a heparin bolus? Probably not, because you're never prepared for this backup swap too. So with the swapping and everything, we normally just have our ECMO specialist do this swap from our Quadrox pump over here over to the hand crank too. Just because they're trained and more specialized to do it, we also have our perfusionists who are also trained with it too. So with this, the types of cannulation that we can have in our patient. We can have fem-fem cannulation, you can have a fem-IJ. You can cannulate pretty much anywhere you want in the patient's body. But the cannulations that we have are like this. So this is our drainage cannula. And I'm going to be completely honest, I work in the education department, so I get the discontinued or the ones that are not actually worth anything. So these ones are the small ones that don't actually go into a patient. So you look at them and you're like, those look huge. They're the small ones. The patients get even larger ones put into them with bigger French sizes. So this cannula with the tiger stripes on it is a drainage cannula. The drainage cannula means that I'm going to be sitting in my venous system, sitting near my vena cava, my lower inferior vena cava, that is able to be compressible by my stomach. So if I'm obese or have acidic bellies or anything that's causing increased intra-abdominal pressure, I get decreased drainage from that patient. The decreased drainage means that I'm not going to be able to flow as high for that patient either. So to offset that, I can put in a second cannula in to help drain from the patient a little bit more. But again, I'm sitting near where that portal vein is, right near in my inferior vena cava. So any compression on the stomach, I'm coughing, anything that's happening, I can get decreased flow from the patient there too. These ones are very moldable though. So if they want to put their leg to their head, they are able to. And that being said, you can get a patient up and walk them if they are femorally cannulated too, because we want to make sure that they do ambulate and they do move around, because that's the best thing for a patient too. Now our return cannula has just a little holes right there for the patient. This is just so it can go directionally, because I don't want blood going in opposite directions of where it is going. I want it going in one direction so I get the perfusion back to my patient. If I'm going into my venous system, it's going to be much longer so it can go up near that right atrium and I can use my heart to pump the blood forward. Or if I'm on arterial return, I'm gonna have this size cannula for the patient too. You can see coming off of it, it has another catheter attached to it. This is the antegrade catheter. Because I'm sitting in the femoral artery, I'm blocking all of that blood flow to my lower extremity. If I block the blood flow to my lower extremity, I lose my leg. If I get a necrotic leg, what's the point of having them on ECMO if they're just gonna get sepsis and die now too? So I need to perfuse that lower extremity, or we're just gonna chop off the leg. Most patients wanna leave the hospital with the same amount of limbs that they came in on though. Now another type of cannulation we can have is a dual lumen cannula. This is where, just like with dialysis catheters, you have one side that's draining and one side that's returning the blood. I have blood draining from over here and blood returning through this part. So I'm gonna float into the heart, just like a pulmonary artery catheter, where I'll drain from the right atrium and return that blood to the pulmonary artery right there. How much do you think this guy costs? It's expired. It's $25,000. So from here, think about what the cannulations, what the cost is before we put this on a patient. Can a patient afford to have this put on them? If they can't, we do work at a nonprofit hospital, but we do want to make our money back so that we can still get paid. If we keep doing it for the love of our hearts, we can do it for some patients, but not every patient too. In the prolonged time of cannulation, that comes out to be millions of dollars for these patients. If they don't have insurance, who's paying for that? The patient. If we don't have an exit strategy, if a patient dies, do they have to pay for their medical bills? Yes. So think before we do all of the interventions that we could. Just because we can does not mean we should for these patients too. Now for our actual numbers, we'll have you come up in a second. We can control what our flow is for the patient by increasing our RPMs. I can increase or decrease those RPMs, rotations per minute. That can cause more hemolysis, which can cause more problems for my patient. But with that flow, I like to think of the flow as adding extra assists to my cardiac output. What's a normal cardiac output? 4 to 8. So if a patient comes in and their cardiac output's 2.5, I could add some extra support to give them that extra support so I can get forward flow and perfusion of my body too. Cardiac output versus cardiac index. We go off of index because it takes into account a patient's body surface area, and then I can actually take care of my patient because their output may look great, but their index is trash too. So we do the index for most of our patients too. Then, I think that's everything. Okay, so now we're gonna have you guys come up and you guys get to touch and play and move around with this machine. And then we'll break up into 5 groups and we'll do a case study. Because the whole activity of this is that we have one ECMO that we can cannulate a patient, but we have 10 patients who want to come in and get cannulated. So each one of your groups will get 2 patients that you get to decide between. And then from that one patient, we'll choose between those 5 patients which patient we should cannulate to. All right, you guys, we're gonna start with our first group over here who has case 1 and 2. And they are gonna say a little brief thing about their patients, or I can if you want. So, their first patient was a CAB ×5 with both refractory RV and LV failure, and their second patient was a severe ARDS patient secondary to influenza pneumonia with a low PF ratio less than 60. And they go with the 42-year-old who's got ARDS secondary to influenza and pneumonia. So with that PaO2 to FiO2 ratio, the PaO2 you get from your ABG, the FiO2, that's where you get from what is the FiO2 on that patient. So what I like to think about is, I draw an ABG on a patient who is on a non-rebreather. I get my ABG result back, and it comes back at 95. That's a normal PaO2. But my PF ratio is then 95 divided by 1. So my PF ratio is in the ECMO candidate range, even though it's just a non-rebreather. Just look at what's going on with this patient there too. Okay. Any of you want to talk? Let me see this one. All right. So they have a patient who is 29 years old, postpartum cardiomyopathy with an EF of 20%. And their second patient was a post-massive MI with a low EF with cardiogenic shock and septic shock. And they are going with the postpartum cardiomyopathy patient. Do we choose the postpartum cardiomyopathy over the ARDS patient? Yes. Okay. Now to you guys. Does anybody want to speak? Give me your paper. All right, then these two patients, they have a 50-year-old female with a PE causing RV failure, and their second patient was a COVID ARDS patient with a low PF ratio as well, who was failing proning and paralysis. Going with the PE with the RV strain. Do we think PE over postpartum cardiomyopathy? Rough choice. PE is reversible. Cardiomyopathy also may be reversible, also maybe not. Which one are you choosing? Postpartum? Postpartum gives you two patients. All right. Do you want to say it?
Okay, so we have a 60-year-old woman with septic shock from pneumonia, severe ARDS, PaO2/FiO2, ratio 55, failing proning, and high PEEP with a previous medical history of COPD, DM2, and HTN. In our other case, we have a 45-year-old man with traumatic lung injury and severe hypoxemia, unresponsive to conventional ventilation with no significant history in his previous medical history. And we chose the 45-year-old man.
Okay. So they chose the patient who's got the traumatic lung injury with severe hypoxemia, who's not getting any better from ventilation. So were you choosing that patient over our postpartum? No. So with all of these patients, though, is it a very easy decision to make? No. We may have chosen one of the patients who was in biventricular failure right when they came out of surgery, and we would have put them on, and then we would have had all of these patients who came maybe 5 minutes too late. It's the decision you have to think about. Certain hospitals, I know at Willowbrook, they have 3 ECMO machines. If they have 2 patients cannulated, they save that third one for any CV surgery they do. If I go in for a bypass, we have 2 patients who need bypass that day. They're saving that ECMO for that patient who's on bypass, because when you go into bypass and you're in that facility, like if we do surgery here, we're gonna cannulate you no matter what, because you're our patient. And maybe we did what was wrong, so we need to do what is right to save you too. So those are also what you have to think about in the back of the mind. How many people do I have to staff this unit? Is it really feasible to have those 25 ECMOs that are making $100,000 a day versus a cabbage that can bring in a ton more money if I turn them out quickly? I don't know. There is no right or wrong answers for any of these patients. We have cannulated all of these patients too. So it just depends on the time and the place that they came through for whether we would cannulate you or not. I'll give you, if you have the ECMOs, we're gonna cannulate you no matter what. I love our surgeons here. They do have a bleeding heart. One surgeon I do not agree with, he says, you have 100% survival until you die. And I'm like, that is true. But also let's think about what the risks that go into this surgery are too. Let's maybe not give false hope. Let's give a practical mindset of what's going on with our patients. Some of our patients too, families will promise left and right. This patient will not do anything. I didn't hear it from the patient. A patient came in, she vaped one time. She got completely whited out lungs, and then she needed a lung transplant. Mom swore she would never vape again. Who came back 6 months later with completely whited out lungs? Same patient. What did we do? She needed a lung transplant. We're not giving you lungs. You did not take the lungs that you were gifted from somebody who lost their life to give you a second chance. So we put her on ECMO. We're like, we will give you as long as you need. We'll keep swapping out the oxygenator to see if you can survive. She sadly did not make it, but that's one of the decisions you have to make. I can give you this, but we only get so many transplanted organs each day that we can give to patients. So we have to make that decision. So think of with that patient, do they have an exit strategy? Yes, this will help them, But is this a bridge to recovery? Do I think they will recover? Great, let's do it. If there isn't a great prognosis, why are we doing it? It's going to cost them so much money. If they die, they still have to pay for it. So just keep that in the back of your mind whenever you're looking at these patients too. And do that PF calculation in your head too when you're looking at these patients, like, oh, they're really not doing great and they're on a non-rebreather. Maybe we should intubate them and we can use traditional therapy before we go straight to ECMO too. Any questions, comments, or concerns? All right.